Good morning, everyone. Welcome from Mount Sinai Hospital in New York City. I, Vishal Kapoor, welcome you for our monthly live broadcast for peripheral interventions. Today, July 25th at 8:11 Eastern Standard Time. Again, we're going to have a great case today, very interesting, being done by PK and team and Dr. Guja. Before we go on to the lab, I would like to introduce, I'm sure you know Dr. Sandeep Singla. He's been a great person. So he'll be moderating with us and joining our team as a faculty. Also, you can watch our cases from previous months on ccclivecases.org under the archive section. We'll have this live case again up and running by the end of the week, which will be uploaded on the website. Please do email us on the link on the website, any questions, concerns, comments during the live case or even after that, and we'll be more than happy to interact and talk. So without further ado, morning PK.
Good morning, Vishal. Good morning, Sandeep.
Good morning,
I'd like to welcome you to Cath Lab Room 6. So we've got an interesting case today, a little less interesting than I thought it was going to be, but it's interesting in any way. So this is the beginning of our new academic year, and so we have a lot of changes here at Mount Sinai, which I think are very positive to show the growth of the program. So we've got two new faculty who've joined. You met Sandeep Singla, who you know from last year's stuff, and then we've got Dr. Atul Kukar, who joined us from Northwell Health. He's going to be joining our webcast starting next month as well. So you know the family here at Sinai continues to grow in the endovascular division. But I'd also like to talk about our new fellow, Dr. Asma Khalik here, who was our interventional fellow last year. So Asma is incredibly trained not only in coronary, but she's done her cardiology in the University of Tampa, right? Tampa General? University of? South Florida. I always remember the hospital. She knows I'm old, so she forgives me. So she's here. She's going to spend a year with us, and we're very excited to have her as well. As you know, the rest of the team needs no introduction. We've got Dr. Guja next to me, who's been with us since the beginning. We've got Ray Lascano, our endovascular nurse practitioner. We've got Elizabeth behind me, who's our nurse, and Damien, who's our tech, and Marichu, who's on our way in as we speak. So we've got an interesting case, and you know, I want you to bear with me because this is not a technically challenging case like our cases have been a lot in the past. But I think this brings up a lot of unique, how can you say, discussion points and decisions that we're going to make. And I'm going to, without further ado here, I'm going to let Asma go ahead and talk about this case, and then we'll take it from there.
Good morning, everybody. So today we have a 71-year-old female who's hypertensive, has diabetes, CAD, the usual metabolic risk factors, is a ex-smoker. She's actually weaning herself off of smoke. She's smoking, she says. Multiple PADs and PTA history. Also has a right above knee amputation as of within the last year. She presents with severe claudication on her left side, which has gotten worse over time. Her medications are aspirin, Plavix, Lipitor, lisinopril, Imdur. Her labs were unremarkable. Her ABIs are significantly worse on the left side. Next. This is a runoff of her left lower extremity.
So I want to interrupt Asma here. I want you to look carefully at this angiogram, and then you'll realize why we decided to do it as a live case, because you know, I'll explain what's going on. But this is kind of explains her ABI of 0.58. You've got diffuse restenosis with focal area of severe stenosis in the SFA, as you can see in the proximal, mid, and distal by the popliteal. You have very, very severe restenosis, showing you with very poor runoff with single vessel in the foot, explaining our ABI of 0.58. But go ahead.
So with that in mind, I would like to bring to your attention our today's discussion, and so we're going to talk about incident restenosis of SFA, which is...
Go to the next slide, guys.
Yeah, next, yeah. So our initial strategy we chose for this lady was going to be a contralateral access, right, CFA. We were going to go with a 7 French. We decided to go 6 French. 45 centimeter sheath. So we usually do Angiomax as our therapeutic anticoagulation. So we were going to do IVIS to rule out thrombus, which is very frequent with these ISR lesions. Accordingly, we would choose a strategy of angiojet versus penumbra. We are going to use an embouchure filter over a bare wire. And then this brings up the discussion of the treatment of ISR with laser versus jet stream versus directional atherectomy.
So I mean, to build on what Asma is saying, I think it's a phenomenal point she brings up. When everybody at home looks at an ISR case, and I want you to remember the one you saw on our film, not what you're going to see, is basically it brings us a question of what's the best way to treat this. So what Asma and I discussed last night with our team is, what is the thought process that needs to go into your mind at home so that you can do this case quickly, get in and out without a problem. And she did it very well. Well, one is, what's your access site, right? Well, obviously in most ISR cases, you're going to go contralateral, especially if it's of the SFA. And I want to be very specific. We're only really talking about SFA ISR here. So SFA ISR, you're going to go up and over, right? And she chose the 7 French sheath for multiple reasons. I think one, it gives you ideas for your bailout strategies. 2, it's going to give you a lot of visualization. 3, it allows you to choose the equipment that you want to choose based on the morphology that you see. So 1. Second is, crossing the lesion. Well, as we talked with her, I think very important to understand that crossing the lesion in the ISR is probably the single most important thing. Well, if it's an occluded ISR and the wire goes very, very quickly without any resistance, then what's going to happen to you is that you're going to that you have some amount of thrombus burden. So a lot of times what happens, like in some CTOs of the SFA, the wire will interact with the proximal cap of the CTO. You'll have trouble getting through. Then it'll just fly down to the distal cap of the CTO, and then you'll struggle and get through. Well, as a hint to you as an operator, what you need to understand is you probably had a stenotic, severe stenosis of the proximal, and then you have a middle column of thrombus and grummus material, and then the distal, you have another cap. So therefore, when you break through it, you know that now you're dealing with this. So that's one. Second is let's talk about imaging, because you know that the angiographic quality that we're going to get with an angiogram is good, but it's not ideal. So intravascular ultrasound, I think, really helps you a lot to identify what's going on. Well, first it's going to identify to you what the material it is. Well, is the material, restenotic tissue, grummus material. Sometimes you can see rocking thrombus material in there. And the second, it's going to tell you the mechanism of failure. Say you have a stent fracture, that's a very subtle stent fracture that you may or may not have picked up inside the stent in your cineangiography. Second is, it's also going to tell you whether or not you have significant recoil in certain areas, and also what type of tissue is it? Is it true in-stent restenotic plaque, or is it much more than that? So that's for intravascular ultrasound. Third is, it's going to help you to size your laser properly. Usually you can do it in ISR pretty easily because you have a 6.60 stent. You can go with either the 2.0 or 2.3 laser, but it's going to help you in more technical areas. Say you want to use a covered stent in terms of what size of the covered stent that you're going to use, et cetera, to be 1-to-1 size. So the intravascular ultrasound is an incredibly important part of your treatment algorithm for these types of patients. Number 3, third point Asma was making is whether you need to use distal protection or not. I'm going to let her discuss the data in a second, but I want you to understand the logic. So the distal protection is going to be used to prevent complications of embolization. Obviously, this young lady has, I think, single or double vessel runoff, which we'll check in a second, and so that's very, very important. So you don't want to take a stable claudication to a critical limb ischemia, although this patient is a little bit more than a stable claudication. Then finally is you want to talk about the therapies that you're going to use. We'll let Asma deal with that. And you want to talk about the anticoagulation. So a lot of people do this on heparin. I do not think it's wrong to do it on heparin. I do not believe that you should use only bivalrudin or anything like that. I think you can do whatever it takes in your lab. Just maintain a therapeutic ACT without having much of a problem. And then I think at this stage I'm going to turn it over to Asma to talk about the filter, to talk about the actual what are the choices of therapy, and then we'll go over what we're going to do here. Go ahead. So slide, please.
Slides. Thank you. Next. So coming to our first thing would be whether to use a filter or not. So this is an algorithm that was published from our lab here at Sinai in JAC. So according to this algorithm, so if you are going for an endovascular therapy and you're choosing to do a atherectomy, depending upon the lesion morphology, If you have significant calcification more than 40 millimeters, then we use a filter. Here by default for a CTO, for a thrombus, and for ISR, we use filter. And if there's an atherosclerotic disease process, which is more than 140 millimeters in centimeters in length, 140 centimeters in length, and also the distal runoff is less than 2, then we use a filter as well. So in her case, she fits the bill anyways. She has ISR, and she has, at this time, right now, she has 1.5 vessel runoff. So we're going to go ahead. We went ahead and
so you have some. So this is a meta-analysis of around 500 patients that we looked at Sinai, that done by Dr. Guja, myself, and Dr. Kapoor, along with Dr. Wiley contributed some patients, as did Dr. Dangas. But majority of us was the three of us. And I can tell you that this is pretty intuitive, because it allows you to study the angiogram. When you study the angiogram, you say to yourself, all right, is this lesion in my mind an atherosclerotic lesion, or is this a thrombotic lesion? Is this a calcified lesion? Is this the ISR? So the definition of calcium is important, because as you know, there are different definitions of calcium. The definition of calcium here, thank you, Ray, is looking at the definitive calcium, the definition of calcium, which is just 1 centimeter on either side of the wall. So basically, concentric is severe, eccentric is mild, and what's it called? 2/3 of the vessel wall is moderate. Basically, that's simple. So if you have calcification extending of up to 40 millimeters, makes it by definition severe. Then generally you need to use a filter. But the beauty here is we validated this by looking at the angiograms and comparing it to the plaque to validate the plaque, validate the ability of the operator to predict the morphology using pathology as the gold standard. And we found that the angiogram was a great predictor of these items: in-stent restenosis, thrombotic lesions, atherosclerotic lesion, and calcific lesions. Once you've done that, you can follow the algorithm and you're set. Go ahead.
Next. Thank you. So now coming to the...
Let's go to the choices.
Okay.
Outline the choices and go one by one.
Sure. So now I'll discuss some of the data behind the therapeutic options we talked about. So the first one here is the excimer laser, which is what we decided to use here. But so let me just discuss the data behind that. So this is the SFA ISR trial, which was a randomized prospective multicenter trial. So basically with the purpose of looking at the safety and efficacy of using excimer laser with PTA versus PTA alone in these FEMPOP ISRs. There were about 170 patients in the excimer laser arm and 81 patients in the PTA arm. Next. They looked at these endpoints of safety and efficacy. As you can see, safety was any major bad things happening like death, unplanned, and amputations, and TLR. And efficacy was, basically freedom from an ultrasound guided binary restenosis and return of clinical symptoms, and also deterioration of their Rutherford class. Next. So this is basically they were they were comparable in their distal protection use in both arms in the percentage stenosis. However, we see that obviously the use of laser plus PTA gave more luminal gain. So obviously you can see that residual stenosis of more than 30% was much less in the laser arm with PTA versus the PTA arm alone. And the procedural success, which is also defined as less than 30%, less than 10 to 30% residual stenosis. So it was better in laser arm versus PTA. Next. So as we can see, most of these complications are better for the red being the laser versus blue being the PTA arm, except distal embolization was more with, actually more numerically more, but not statistically significant with the laser arm, which I guess we expect because it's doing, it's macerating the plaque. It's it's debulking, so it's shoving more material distally.
And that's why it maybe highlights probably the use of filter makes sense here.
Absolutely, absolutely. Next, please. So now this is the primary patency at 1 year they looked at, and we see that it's better in it's statistically significantly better in the laser arm, which is highlighted here in blue, versus the yellow one, which is the PTA arm. Next. And similarly, the freedom from TLR is also better in the laser arm versus the PTA arm alone. Next. So to summarize, the use of excimer laser with adjunctive PTA for treatment of ISR is considered superior to PTA alone based on the fact that, it was used to treat complicated lesions up to about 19 centimeters in length. And then significantly higher procedural success, which was 93% with laser versus PTA alone was just 82%. And also statistically significant safety rates with laser, meaning freedom from any major adverse effects were 94% in the laser arm versus the PTA were only around 80%, and this was statistically significant as well. And like we highlighted, the TLR was definitely less for laser arm as well. So, this is what led to actually FDA approving use of laser as a therapeutic modality for treatment of FEMPOP ISR. Next. So the next important topic, which I want to highlight here, is the use of endoprosthesis, and I want to talk a little bit about this trial, Realign. Next. So this was a trial that looked at Gore's Y-band device and compared that to POBA alone for the treatment of SFA ISR. So it was again a multicenter randomized trial, looked at Rutherford class 2 to 5 with patients with ABIs of less than 0.8. So the criterion for inclusion of the trial were about, like I said, a long ISR. It could be between 4 to 27 centimeters, and they needed for this a minimal 1 centimeter healthy vessel on either sides, just to land the stent, so that we could end our graft somewhere. And also the popliteal artery had to be patent at the intercondylar fossa, and as well as they, for the Y-band to stay open, we need at least, as we know, 1 vessel run off downstream. Next. So this is the trial, and this is the patients of Y-band arm versus the PTA arm, and they're comparable, around 44 and 39 in the Y-band arm. And the stenosis were comparable, and they were about 1/4 of these were total occlusions, and the calcified lesions were also about a quarter. Next. I want to also highlight here that the first graph demonstrates the primary patency, and the second graph demonstrates the freedom from TLR. As we can see, they're also both statistically significant in Y-band arms. So this is the 12-month data. They also have a 24-month data, and the curves continue to stay divergent, but around the similar, like 80% in the Y-band arm freedom from TLR, and in primary patency versus the PTA alone was 40%. Next. Okay, so
now I want to interrupt Asma here. It's doing a great job. So now you basically have topics where you take an in-stent restenosis and then you debulk it or you cover it, and then you do bulking it, balloon angioplasty. As we know, the pathology of in-stent restenosis is obviously intimal hyperplasia, healing gone wild. So the question of whether drug should be instilled or not was actually studied. And that's why we kind of bring up this topic. So now, Asma, you go ahead and present what you have on that.
So there's another important topic that's emerged in the last few years, which we did not have before, which is the DEBs, the drug-eluting balloons. So one of the trials here is the impact. It's actually not a trial. It was their data from the registry data, exactly. So it's a kind of a single arm study. So they looked at all of these were ISR patients. They their baseline risk factors had the usual metabolic risk factors. Next. Okay. So around 150 patients in this that they studied or looked at, and so what they saw was the use of impact. This is on the right. You'll see the procedural characteristics. They said they around 100% of them had device success and as well as procedural success, and these were they used different definitions of procedural success versus device success, and obviously clinical success was based on MACE and recurrence of symptoms. And on provisional, just to highlight, provisional stenting was needed only in about 15% or so of the patients. Next.
So wait, but go back one. So interestingly, if you look at you have a 149 ISR, lesion length is around 17 centimeters. On average, total occlusions were 34%. They had some calcification associated with the ISR. Reference vessel diameter was around 5. So you're talking about a vanilla ISR kind of case with long lesions, vanilla ISR, very similar to Excite, which also had long lesions, and very similar to the Viabond, which also had long lesions. We know we can't compare trials, But clearly, this is a situation where it is a real-world lesion. Important to remember, all three of these were core lab adjudicated. They had a clinical events committee, and even though this is a registry versus a randomized trial, you would still had a clinical events committee. You had your core lab, both duplex and angiographic. So all these were source verified patients. So this is reliable registry data, not crappy registry data. Next.
Next. So they looked at the 1 year primary patency for the impact ISR arm, and this cohort had like Dr. Krishna mentioned, quite comparable to the others. It was around 75 or 80% in the other two that we saw, the Vyban and the laser data, so around 88%.
Well, 88% at 12 months, and the window was at 80.7% at day 390. So I think it's very, very comparable. Obviously, this is not comparing to anything else. It didn't compare it to angioplasty, but at the same time, you do have at least you can't compare trials, but at least you get an idea that that's kind of the ballpark.
Right. Next. So similarly, now this is freedom from clinically driven ISR. So the others was obviously ultrasound determined primary patency, and now this is clinically driven ISR, which is around the same 92%, which is quite great at 1 year. Next. So again, this basically skip it. Next, please. Okay. So now again, I just same. This is talking about the same primary patency of 88, and the freedom the freedom from we said was around 90%. So this basically says that 12-month clinically derived TLR was 7.3%. So this confirms the effectiveness of impact impact DCB in treatment of ISR. Next. So this was an interesting trial. Also looking at it's a debate ISR trial looking at a non-impact balloon. In the treatment of ISR. If you go to the next slide, please. Next slide. Yeah. Next. So here at this is looking at it's for around 400 days, so a little over 1 year. So you can see that the solid line is the DEB and the dotted line is the PTA. So around 86% 1 year outcome freedom from TLR as well.
As compared to PTA.
As compared
to
PTA.
So now this is your randomized comparison showing that the impact balloon works against PTA, because we know that the global was just against nothing.
Nothing, right. However, go to next, please. Yeah. So this is a little interesting, data here, but I want to demonstrate that although the DEB works, and we know the drug works, but when they looked at the same data at 36 months, you can see the curves overlap, which basically highlights that this is what we know about of this SFA ISR, that it's a nuisance. It's going to recur. We might be able to stop it for some time, but eventually even the DEB and the BA, meaning the PTA, they converge the curve. So there's a catch-up even in the DEB arm. So next. So then that brings us to another thing, with another important topic of Zilver, or the paclitaxel-coated stent in the treatment of ISR. So this is again a single-arm study. It's Zilver's, they looked at 142 of their patients and the lesions that they treated with ISR versus 900 of them were native. And again, lesion lengths of around 50. So these were, their lesion lengths were, if you see, more than 7 centimeters, and majority of them were just more than 7 centimeters, and more than 15 centimeters were less than 1/3.
So these are relatively shorter lesions as compared to the impact global cohort, and the Reline is definitely shorter than Reline, and definitely shorter than your Excite ISR.
Excite as well, yeah.
So
next.
what were the results?
Right. So again, quite comparable. So this is it's a bit interesting. They're comparing to Zilver in native lesions versus Zilver in ISR, and they show around the same at 1 year and 15 months, around the same. They show around a freedom from TLR of about 84% in Zilver in treating ISR. Next. And this is their primary patency, which is around 80% as well, versus in treating de novo lesions. Next. That's it. So those are my acknowledgements. Thank you, everybody.
So I think that's a great presentation. I mean, honestly, that's what they call is a tour de force of ISR in 15 minutes. Great job, Asma.
Thank you.
So guys, I want to, before I get to what Dr. Guja and Ray have done, I want to throw it out to the three of you in terms of what you've assimilated what Asma has done. Tell me, let me start with Karthik. Tell me your algorithm, Karthik, when you look at this. Just don't tell me why, but tell me what your algorithm is when you're treating ISR.
So depends on what ISR contains, right? If it's just restenosis.
So you do IVUS in all of them?
Yeah, I do IVUS on every ISR case.
Okay.
Just to see if there is thrombus mixture along with it.
Mhm.
So I feel like every ISR, if it's in the advanced stages of ISR, not like a vanilla case, but has some component of chronic thrombus in it. So that's why we use a filter in every case.
Okay.
So then I use a laser. Laser is probably the perfect device to use in ISR cases, especially if there is some mixture of thrombus in it.
Followed by?
Followed by DCB.
Okay.
That's
So we have. I'm just going to go one by
Yeah.
one. So you stop. So Dr. Guja likes a filter, laser, the DCB. Dr. Kapoor.
Yeah, I mean, I guess, again, like adding on to Karthik's point, evaluation of an ISR by an IVUS is very important for me as well. And then the degree of ISR. If it's a long diffuse lesion, then I use a filter like per your algorithm, like you said, or per our algorithm, like we said. And then if there's a thrombus component, I do a aspiration thrombectomy, and atherectomy together with one of the pathway devices. If it's a very focal lesion, then I'll do a directional, I'll do laser if it's long as well. Or if it's a very focal instant restenosis, you know how you have edge or distal, I'll probably just do a directional atherectomy, get the plaque out. And then I usually like to do DCB as well because I'm not a big fan of putting another layer of stent or a covered stent if it needs to be done. So usually DCB is my first thing to go, unless it's a failed DCB from prior intervention.
So you're a little different. You base it on the location of the ISR. So if it's distal, just outside at the edge, you like directional atherectomy, which we know is off-label, and that's fine.
Right, correct.
If it's within the body, you do IVUS, but you may do a jet stream, or if you suspect thrombus, to macerate and aspirate,
Right.
and or you may do laser. And then you rarely do stenting and Vibon, and what you tend to do is do a drug-coated balloon after.
Correct.
Okay. Dr. Singla, what about yourself? What would your algorithm be?
So, in an ISR, I kind of look at it as three things. One is doability of a procedure, second is durability, and third is my follow-up. From a doability perspective, Dr. Krishnan, as you mentioned, the wiring is important. That tells you about the lesion, and how the wire behaves across the lesion. I'll decide if I need to do any thrombectomy. The protocol we have, I like that. I will use angiojet followed by penumbra. And I will definitely use a filter. AmbuShield is my preferred filter. If we have other options also. Then, anticoagulation angiomax, we all agree upon. I would definitely do IVUS, not only to tell the characteristic of the lesion, it will tell me if there is any undersizing if there is a stent, it will tell me of any undersizing. Now, the more important thing in, restenosis is that what was the first therapy which failed. If it was just a DCB which failed, I would avoid, the intent is to avoid scaffolds and intent is to avoid covered stent. So let's say the first therapy was DCB, I would definitely consider a scaffold as a second therapy. I can go drug-coated stent DES, Silver, or I can go DCB, another second DCB of a different company, plus another scaffold.
But Sandeep, we're specifically talking about ISR, in-stent restenosis.
Oh, instant. Then, if we are instant, I would. If it was a first failure, I can consider Silver. If it was not Silver, I would definitely use some atherectomy, laser preferred. And let's say, this is, I do not identify a cause. There was no undersizing, and it's a diffuse. And let's say there are already 2 layers of stent. I would, at that point, in my mind, I would think of reline.
Okay.
Now,
So
the problem, I don't mean to interrupt. The one thing which I have to keep in mind when I think of reline is, it's kind of under the rug. What happens is when we use covered stent, we have to always think about anticoagulation. This is a lady, let's say, in our index case, 77-year-old lady, multiple risk factors for the bleed risk. If we put on an anticoagulation, if I remember correctly, I haven't looked at the data recently, I think there was a 9% incidence of thrombotic occlusions of covered stents. And once the covered stents occlude, that's a big thrombus load.
Yeah.
And we deal with it, and it's a pain for everyone.
Right.
So-
Those are good points, but I think I'm curious to see. Let's because I want to get to the case, which is going to be in a second. If you look at it, Karthik and Vishal and Sandeep, there's DCB works in the intermediate phase, right? Out to a year, 2 years, 24 months, you got a good result. You know that from debate ISR that Asma presented so eloquently. So if you're saying, I don't want to leave something behind, let me just do a drug-coated balloon. But then now you have to deal with the catch-up at 24 months. With the Excite, you only have 12-month data, and I think 24 months has shown there's been some catch-up as well. And then with Zilver, you really don't have anything other than registry data. You don't have any randomized data, although there's pros and cons of putting in another stent. And with Viabon, again, you've got the thrombotic risk, and you've got issues with another prosthesis. So I'm going to ask you the value of debulking with DCB, because I'm curious to see what the three of you are thinking. Do you think adding a atherectomy of any sort, I mean, in this case, we're going to do what we're going to do, atherectomy of any sort, and then going ahead and adding a therapy would help prolong your failure of restenosis? Karthik?
So I personally feel yes, because I think instant restenosis is a totally different animal when compared to a regular atherosclerotic lesions. These are more fibrotic. They are not just intimal hyperplasias. They are overgrowth. So I personally feel debulking and lining them with DCBs is pretty significantly impact on the patients.
What about you, Vishal?
Well, I guess the good point about endovascular peripheral world is we have data coming up, but there's so much gray area that you have so-called good flexibility if you want to take it that way. The bad part is we don't have a lot of randomized trials to prove one works with the other. Like you rightly said, if you have a 3-year follow-up, there's a catch-up of DCB with ISR, but there is not much follow-up data on reline and all the stuff, so it's hard to compare one entity versus the other. But atherectomy-wise, I'm a big fan, pretty much like how you and Karthik are, about debulking, getting the lesion off, because I mean eventually it's all about, if you're using DCB, it's all about delivery of the drug, preparing the lesion, preparing the site, hoping for good results, which is what our goal is. So I do believe if there's a lot of disease burden to debulk, and if IVUS shows there's a lot of stuff going on, then I would probably do an atherectomy and then do my secondary mode, which are DCB, DES. Or
what about you,
like.
Sandeep?
I agree. I would definitely debulk and use a DCB. One, I believe that would help the drug go deeper into where the media is, where the injury is happening, where the stent
Well,
is.
you got to wonder what the mechanism of failure is
right.
when these come back. If it's not thrombotic, which most of the time it's not, you have thrombus component because of slow flow, but I don't think that's the initiating event, then you got to wonder why. So the question is the drug which affecting the tissue? When you balloon angioplasty, these ISR lesions, you basically dehydrate them. When they rehydrate, they tend to restenose. So the question here is whether you atherectomize it, actually debulk the restenotic tissue, then go ahead and add the drug, which may then prolong. I mean, this all needs to be seen. I don't think, unless you have an actual mechanical failure of a scaffold, I don't see scaffolding as being the answer, and I agree completely with Karthik. So listen, we've had a lot of debate, a lot of talk. It's been 35 minutes we've been doing this. I want to underwhelm you with our angiogram. Go ahead.
So I'll tell you why it happened. So we did a iliac picture. I'll show you why she was brought in mainly. So you can clearly see that if you see the iliac shot, you know the amount of disease, the amount of stents.
And the right side she has an amputation.
Yeah. So this angiogram which PK showed was about 1.5 years ago.
So New York being a migratory population, she's probably gone somewhere else.
Right. So she went to another hospital with an acute stent closure on the other side because we sent her for bypass last time because she failed DCBs and a relining with another stent, silver. So we sent her for bypass, and I think she went somewhere, another hospital, outside hospital, and she had the amputation when we were not around. So and you can clearly see. So look at that. It looks like at that time, about 1 year ago, they revascularized the left side also. That part I knew. So
then here, this is a good scout film that shows you there's no fracture.
right.
And then here you see Dr. Guja does a shot.
This is one line of stents. So she has a history of having significant restenosis very quickly. So the data I got from the outside hospital is they did atherectomy and just plain PTA. They didn't line it with DCB. They didn't do anything. She suddenly comes in with complaints of left-sided pain, cold sensations in her feet, right? This is exactly how her previous history has started. I know her for about 4 years now. So she has a gangrene. We saved her right leg again, you know. These patients are significant atherosclerotic patients. So we did an ultrasound. On the ultrasound, ABI clearly showed it was 0.74, and we had a private ABI, so we didn't worry about doing an ABI. I did an ultrasound because she's an ISR. Ultrasound clearly showed like where there was an overlay of 2 stents, there was significant velocity increase, tripling of velocities. So and on, if you remember the previous angiogram, she had 3 vessel outflow. So on the ultrasound, it showed that she had only one clear 1 vessel outflow. So I was concerned.
Well, you couldn't tell that she had 3 vessels. She possibly had more than 1 vessel, that's for sure. But it was very hard. But you can tell that she's had something done. She has had clear flow all the way down into the pod. It's worrisome that the collateral still fills below the SFA, but then she has straight line flow. She has got the perineal lux stenose, posterior tibial occludes, and the distal occludes. So anyway, the bottom line is she's had a procedure done prior to this, which we did not know about. And clearly that now she's here for this lesion. She does not have CLI, so we're not going to go after the posterior tibial. What we are going to do right now is fix that ISR, and maybe a blessing because Ozma did such a great job with that. We're going to have a shorter case to demonstrate the things that we want to do. Can you put up the IVUS, guys? I want to show Dr. Guja. Put up the IVUS, and Dr. Guja, please, or all of us can read the IVUS. Karthik, please.
Can you play it from the beginning?
He's going to do it.
You have to lower down the
red stuff has to
the
come
red
down.
stuff has to
bar
come
has to
down.
come down.
The red one has to come down.
Yeah, he'll do it. Is our IVUS team around? Is
It's okay.
Kevin around?
It's okay.
So anyway, so the point is with intravascular ultrasound, we were able to confirm that there's no stent fracture. And because there was no stent fracture, it made us happier that there was no mechanical cause of the failure of this particular device. So now we're just going to look at the plaque morphology now. And you can tell this has been treated because of the morphology of how the vessel and the plaque looks at this level. You'll see it in a second.
So before we go to the IVUS, let me ask PK and Karthik, what's your threshold of, keeping aside the risk factors, what's your threshold of sending a patient to surgery? Fail how many times, or what modality you start thinking, okay, you know what, probably it's not working? Because like Asma presented, debate ISR, DCB eventually catches up 3 years. Reline study, 2 years, patency rate is down to 50%. So essentially whatever modality we are doing, like you rightly said, ISR is a totally different animal. When do you start thinking, okay, we're not achieving the results we want to, and let's get surgery involved?
Which are my policy is a little different than PK's and I think Sinai modality. I never reline the stents. I feel like relining, unless we have a focal lesion, I can reline the stents, but I try DCB. I know that DCBs, every 2 years, we might have to revisit the lesions and do DCBs. I'm fine with that, as long as relining, because I think relining puts them at a risk for acute occlusions. So if I think that the targets are nice, I never stent the popliteals, period. So I know for sure my patients, they have targets for popliteals. If they have a target for popliteal, I just send them for FEMPA.
So I mean, I think as you know, I think it's not that we reline everybody. We actually rarely ever use a covered stent. I think the point is, there has to be logic to what you're doing. If the patient is failing because of a mechanical failure, you have to treat the mechanical failure, or else, I always say this, you either poop or you get off the bed. The truth of the matter is that if you don't treat the reason why the patient fails, then you're never ever going to make the patient better. So if you have a mechanical reason why this patient failed, then stent the lesion. There's nothing wrong with that. If you think it's a stent fracture and you want to put a supera in or a short Vibon in, put it in. However, you got to think about three things, and this is what we think about, is well, what's the runoff, what's the distal disease, and what's the proximal disease? As Asma went over so beautifully in her presentation, if you look at the Gore-Reline study, they wanted to have a 1 centimeter disease-free segment distal, and they wanted to have a disease-free segment proximal. They did not extend it into the P2 segment, and they wanted to have at least 2 vessel runoff. So, you know, it's all pretty outlined to you on what you need to do. Every therapy is going to fail. So for you to say that one therapy won't fail or one therapy will fail or I'm doing this or I'm doing that, the answer is we don't know. I think that the truth is you have to have a logic to what you're doing, and you have to understand what are the complications of each therapy. DCBs can thrombose. DCBs can embolize. We've had issues with all the devices, and DCBs definitely restenoze, and we have late catch up with DCBs. So the important thing here is surveillance, watching the patient closely, surveying the patient for restenosis, watching for velocity shifts, especially when you have a covered stent, and then treating the patient appropriately, whether it's bypass or not. So I think that's very important to look at it in this manner, because we have no head-to-head randomized trials, bypass versus angioplasty. We have in ISR. We have no head-to-head trials, DCB versus atherectomy, or atherectomy DCB versus this. So we're trying to actually navigate the waters without an actual compass or without a navigation chart. So it's very difficult, but I think that the discussion here is very healthy in highlighting what the thought process is. So that's in a nutshell what we do here, Vishal. So we're going to do the IVUS manually. So we're going to, for whatever reason, we have an IVUS issue. So we're going to do a manual IVUS here. Go ahead, run it down, guys. So go ahead, Karthik.
That's from the POP, and you can see some distal restenosis at the edge of the stent. You can see there's a lot of restenosis in the stent. There's a lot of intimal hyperplasia. You can see it. As we keep running, normally you can see this amount of hyperplasia in stent, which is okay, as long as there is no significant hyperplasia. I've always believed, and I think PK taught me this, but you always start with focal instant restenosis, and then you start thrombosing, and that's when you start having all this issues with the long stents.
So again, as Dr. Guja says, you can see that there is no failure of the stent. The stent is very intact. So the integrity of the stent is good. So in your mind, unless you're doing multiple angles of your II and giving yourself radiation, you know that immediately off the top. Then you can see the plaque also is there, but it's not obstructive. There's no obstructive plaque in the distal aspect, and in the proximal is when Dr. Guja, as you see angiographically, it correlates very well to a focal plaque. So Vishal, can you talk about the plaque that you see and what are the things you look for in the plaque? It looks like 2 layers there.
Right,
layers
exactly.
there. That's right.
That's what me and Sandeep were talking. It looks like as if there are 2 layers right there. And
So
like you rightly said, it's all, Karthik said, it's diffuse intimal hyperplasia. There was another spot which was very focal up on the top.
Just right before the 2 layers.
Correct, right.
That's exactly where the ultrasound or vascular ultrasound also shows elevated velocities.
And right there as well. See,
Right
there you
there.
can see that soft plaque / neointimal
So-
fibrosis. But I don't see a lot of thrombus, which you would see in quite a decent number of patients with ISR. But I guess in this case,
So Vishal, I think that's what I was reiterating. Like, when you do vascular ultrasound follow-ups for these patients, when you see these kind of elevated velocities and focal lesions, if you bring them back and address these lesions when they are focal like this, with increased velocities,
Great point.
I think you can avoid long occlusions and everything.
That's a great
I think
point.
that's especially when they have mild symptoms. You don't have to wait for them to have severe occluded symptoms like we do in claudicants. These patients are different animals. They are not regular claudicants. Last thing you want is for them to occlude the whole stent and start thrombosing the whole stent.
well,
So-
I guess just being a devil's advocate, you know how it is. The trials nowadays are all based on clinically driven TLR, meaning
How far
when
is
the
the wire?
symptoms
Distal,
are coming, when the patient is doing. So I know we should do
Okay,
regular
make sure.
follow-up ultrasounds, but I guess the issue also becomes is when is the patient getting symptomatic and then putting 2 and 2 together and treating rightly. Of course, identifying a disease early on and treating it and helping the patient's symptoms is our goal. But again, like I said, it just becomes a tricky part.
like any other ISR in coronaries or anything, these ISRs, peripheral ISRs, keep going. You can go at the double layer.
No, it's not going.
Yeah, it will.
So guys, let's talk a little bit about settings, IVUS settings,
Yes.
and the setup here, Karthik. Can you go over what we did here?
So once we did the IVUS, so we are taking a laser. So I choose laser based on the stent size. I know that these stent sizes are 6.0 and there is a Supera which is a 5.5 because I put it in. I know that. So it's a 5.5 stent size and she's a very small lady. I felt like taking a 2.0 laser should be big enough. But if you go with a 6.0 Superas or a 7.0 stents, within stent, if it was proximal instant restenosis, I would have definitely considered a 2.3 laser because it's a 7.0 stent. But here we are starting right at the overlap, and the stent is a Supera 5.5, so it's almost like a 5.5 lumen. So I'm taking a 2.0 laser, and we normally start off with 60-60. If it's my personal preference is 60-60 when I start off in an SFA. If I start off infra-pop, and if I start off in a CTOs, I go 45-45 and then ramp it up as necessary.
So the other setup also is important, Karthik, is you can do the flush in multiple different ways. You can put an end deflator at the end of the laser and turn it on. We tend to be a little bit more generous and vigorous. We put a flush to the side port and let it open. We lose pressure at that time, and generally it works very well. We've done lots of lasers without a problem. The second is I'm gonna go ahead. We're gonna start the laser here. So go ahead. We're gonna do 60-60 on, please. So we're just gonna go very, very slow, very, very slow. You really, I think the key, like all of us do, is you just want to let the laser create the vapor bubble and then slowly go through. You can almost see the vapor bubble there forming in front of the laser, and that's what's going to do the ablation, right? Without the vapor bubble, you don't have ablation. And she's going to feel that. We know that. And you can see now very carefully how the other stent is underexpanded inside the Supera. You see that? I don't know how it shows to you,
Yeah.
Vishal,
Yes.
but you can see the other stent, at least for where me and Karthik are standing, it's clearly underexpanded. So it's interesting that the IVUS didn't show us that very well, but I can see it here in angiogram, and I'm just going to do it very slowly here, and I'm going to come out distal. I think we're fine here, right, Karthik?
Yeah.
Okay, we're going to walk it back and do another. You want to walk it back again and do another one here?
Yeah, one
I think
more
we should
round.
do another one here, and we're going to. I think at this stage go to 80-80.
Yes.
Okay, and then we're going to go. She started feeling it,
So
so you got to be a little careful.
So Vishal, Sandeep, and PK, I want to ask a question. This long ISR patients, right? All three of you guys.
I'm sorry,
San-
66.
Sandeep, we can start with
Go,
you.
on.
How do you follow up these patients? Do you do ultrasound? Do you do AVI, PVRs? How do you do them?
By guidelines, I think we should do an ultrasound.
Right.
And I think the recommended one is 3 months and 6 months and then 12 months. If they
Yeah.
are stable, I would follow them at least 6 to 12 months.
Right.
And
the
as you
vapor
rightly pointed out, the big point is you should not wait for them to get occlusive, because that's when they form thrombus. So
Off.
even if they have like minimal
Okay, walk
symptoms,
it out, take a picture.
this is kind of a surveillance angioplasty. What they do with grafts, they preemptively treat it, and that's what is called the primary assisted patency. We don't have to wait for the secondary patency. They don't have to go to occlusion.
Thanks, but we'll leave it on. We'll maybe.
So
take
that
another
would be
shot.
my approach,
Turn
Karthik.
it off. Yeah. So I
Sorry.
think it's important to talk a little bit about that. Surveillance is very controversial, and I think why I'm saying that is surveillance was initially done for bypass grafts, right?
Yeah.
Look at that.
Uh-huh.
Look at the thrombus. You see that? You see the amount of thrombus in there now? Watch this.
Yeah.
Oh my lord.
Where did that?
See that?
Yeah.
That's very important. So this is why the filter becomes very, very important. So now the point here is you've got a better lumen than you had. Hopefully, you clearly have debulked and you've done this. But anyway, let me get to my point on surveillance. So surveillance is really done for bypass grafts initially, right? So we've applied that in the peripheral, and really the surveillance in the periphery is really to do what Dr. Gu just said. You want to look at velocity shifts to decide whether or not you should intervene. But I say in a stable claudication, if you have velocity shifts, probably it's better to intervene, because if that occludes the way Karthik said, then the problem becomes that it's now going to get much worse and more difficult to treat. So now I'm going to go ahead and cut this now with a angioscope. Can I get a 6060 angioscope, guys?
Thrombus?
Well, the question is, would anybody aspirate this, or would you say let's just balloon it because you have a filter?
That much thrombus.
No, I mean, look at the thrombus burden. I would probably aspirate it just to be. I know you have a filter, but nothing is 100%. With that thrombus hanging there clearly, I would probably do one run of aspiration of
All right,
whatever
so let's get a
modality you
penumbra,
like,
guys.
Yeah,
I agree
penumbra.
totally. Let's get a penumbra.
and then you can
see what it looks
So
play around with
again,
it.
I
And a
mean,
filter
this
picture
is
at this time.
supposedly a simple, procedure in a simple ISR patient. Now you're dealing with significant thrombus there. Now remember, this could be either thrombus or it could be prolapsed plaque,
Correct.
right? So it
Yep.
could be one or the other.
Yes.
So therefore, you don't know what it is. So it's probably not wrong in running an aspiration catheter through. I don't think angiojet is going to help you here because I think this is
Yeah.
now actually formed,
Thrombus.
complex stuff. So if you do angiojet here, you're going to get in trouble. So just do a embolectomy or a thrombectomy with a penumbra device.
Well, the good point is you have the IVUS open. So if you want to run the IVUS,
Ah!
you want to see?
I love it. Give me the IVUS. I tell you, Vishal, you had breakfast this morning. You really did. Karthik and I are still sleeping. You had breakfast.
I'm well fed.
Actually,
yes.
you're right, man. It's a brilliant idea. We had the IVUS open, and might as well do the IVUS.
So Vishal, this is the reason I have very low thresholds for instant restenosis. Just imagine one small focal lesion we are trying to do here. I think this is the reason this case was brought to demonstrate how even small focal ISRs can also become very difficult, especially if the stents are put like 4 or 5 years ago, because they form pockets of atherosclerotic lesions, like kind of ulcerated plaques, and they have some thrombus in it which you probably cannot recognize just by angiography or even sometimes IVUS.
So here we go. I'm going to go distal. I'm going to pull back. Ready?
I am.
Record. I'm going to come back much slower because I had my coffee this morning. And you can see here as we come back, you may not see anything. I got to put on ChromaFlow, guys.
Yeah. See, there is
Stop.
right there.
Stop. Put on ChromaFlow.
See, that's why I was saying, Vishal, sometimes you cannot appreciate thrombus because
I understand
Chromoflow?
it's a freshly formed thrombus, so it's
Yeah.
pretty much like how the DVT ultrasound is. You can't
also, I
really
mean,
see.
6
it.
to 8.
yeah, in ISR, remember, all these thrombuses are organized thrombuses.
Give me a
They might look like
ChromaFlow.
plaque. So it's hard to appreciate them.
Thank you. Thank you. So this is the area we kind of saw it. Give me a little dye to see whether it went downstream.
Yeah,
Right
it went
there.
downstream.
No, we don't know. There it is.
Right there.
See
Look at that.
There it is.
That's your
See
plaque.
that's your plaque. See that?
Yeah.
It's
So you can
dangling
see
in
the
the bruise
plaque.
right there. It's plaque. It's not thrombus. Okay, good. So let's try to aspirate it out. It's definitely loose. Now the
a
question
thrombus.
becomes, guys, let's get
It's
interesting
hypertension.
here. So now
fresh.
say this is
Plaque
plaque
has been
prolapse
prolapsed.
now. Now what are you going to do? Are you going to stent this with a third layer? Or are you going to reline it with a covered stent?
DCB it.
DCB.
DCB it.
Why do you
if-
think?
what
now,
if-
so this is mobile plaque. So why
Yeah.
couldn't this embolize? We don't know. So the answer is we don't know. So the
Should-
point is,
should we do a filter
why
picture
would you
next?
take the chance? Is my question. Or would you anticoagulate her? Well, it's plaque. Anticoagulation is not going to help.
exactly.
So we don't know the morphology of this tissue. Intravascular ultrasound has illustrated the plaque to you, but you don't know. So this is an interesting question. Sandeep, what would you do?
PK, you
I
really think
would-
that's plaque?
That's plaque.
I think that's thrombus.
I think that's
it's-
thrombus.
Why would it be thrombus?
I
It's
think
hard to
that's
tell.
thrombus.
Because you can
it's
see
hard to
the
tell.
flow,
Laser can create heat and it can definitely
Yes.
develop thrombus.
and especially
I
when you.
personally think it's thrombus.
I think you have no idea of knowing what it is. That's the truth. I'm telling you. I don't know it's plaque. I'm saying we all don't know what we think
Okay,
it
play
is.
it
What
again.
it is.
Play it.
We have no idea. But I mean, so the point is, if you don't know what it is, how can you treat it?
No, but
Other
at this
than
point,
aspirate it, right?
should we look at the filter, make sure there is nothing there, and then second is, if DCB there is still luminal material, I would do a covered stent, short covered stent.
That's what I'm saying. Let's take a
Can
DSA. Inject. Oh, you can inject. I'm precluding. That's okay. This DCB is fine.
Can we, take a picture of
Filter
the
is
filter
fine though.
and the same spot again? I just want to see if it's still
Yeah,
there or
No,
not.
exactly.
I can't inject because I'm
Oh.
included with the with
With
my
the laser,
penumbra.
with the penumbra. Okay. that's
Oh
fine.
yeah, yeah.
we
Because
can
that
inject
would,
Tight for some reason. It's not moving.
So we can take
Okay,
picture of the
okay.
penumbra.
well, then we would
then we
never
won't
know
know.
All right, guys,
whether
turn it
it's
on.
thrombus or not.
Okay, we're aspirating. So the penumbra device, Sandeep, can you go over the penumbra device for everybody?
So, penumbra is an end hole. It's like it basically creates a negative suction and almost a 0 environment. And it's an end hole suction. Similar to what we use in coronary world, it's like what is this? Pronto. And the one thing to watch with the penumbra is that it can suck out a lot of volume. So don't start it till you are proximal to the lesion, and it's over the wire. And
Walk it back now.
and another thing to watch with penumbra is if it's getting occluded, you can use a second wire
Let's try now.
and kind of use it as a what do you want to
Buddy wire.
as a buddy wire to make sure that thrombus is non-occlusive and it's sucked in.
So one of the
So-
disadvantages here is it's not torqueable. So a lot of times I use a multi-purpose catheter to be able to aim it towards the lesion, walk it out. I think we're off, and I think that what he's saying is very true because you don't know exactly what's happening. So remember, I think that if you aspirate too much, you could end up with what is it called, the anemia induced by yourself.
Yeah.
So you definitely need to make sure that this is not an issue. And the final thing is to bleed back the sheath the way Dr. Guja is saying. But I tend to just look at the pressure, and if the pressure is good, we're okay.
And
Flush
then
forward,
the
guys.
catheter sizes, Dr. Krishnan, like Cat 6, Cat 5, and Cat 3. So
Okay. DCB. I mean, let's take a picture.
Yeah, let's get it.
DSA. That's fine.
So I think it's thrombus.
So it could be plaque too. Thrombus or plaque, it's gone. And I think aspiration was the right choice. We're just going to check our
For
filter
plaque?
now. Very important, guys, to go down and check your flow distally at this stage to see where we are. And,
One second.
it's good. You can see it. Really, just want to see the filter. So, and the filter is empty.
filter is good.
There's a little bit weird flow
It
distally.
looks good.
Well, that may just be because I'm overlapped here. Let me see. Yeah, I'm
80.
covering it. So that's
80
fine.
looked.
So we'll just do a picture of the distal vessel. And I think at this stage, we're going to go ahead. I think the consensus has been to DCB it. Would you guys cut it before you DCB it?
No.
no,
No, you wouldn't. You just DCB it?
yeah.
Yes.
I would absolutely cut it. I'll tell you why. Because you haven't got a big lumen. And you have to look at the DCB as a vehicle for delivering drug. So here you don't have a lumen that's large enough
40.
to apply the DCB. So you debulked it, I agree, but you definitely want to cut. So when you cut this, I know you're adding expense, but now in this case, now you've added a thrombectomy code to this patient because of the fact that you've now created thrombus. So you clearly have a more complex procedure. So now we're going to go ahead and cut this open, and then we're going to use a drug, and we're going to be done. I have a question. What if you cut it and say it is thrombus and the thrombus comes back? What do you do then? Do you put DCB in acute thrombus?
No.
Or do you leave
No.
it just with a cutting balloon and leave it alone?
So I would do a DCB because I think the thrombus formation is because laser creates heat.
But Karthik, that's not true, because in all the laser trials, the thrombotic events have not occurred. So including the randomized controlled trials. So I think you even if we think that laser creates heat and heat creates thrombus, that hasn't panned out in the randomized controlled trials. So I think that's very difficult to say that this is because of the laser creating the heat, because then that's implying that the laser creates thrombus, which is not true. Because one of the uses of laser is in thrombotic lesions. In
Right.
thrombotic lesions, they believe that using the laser will be able to actually get rid of the thrombus. You want it right there, right? We'll actually be able to get rid of the, maybe a little bit proximal, huh? Because you're a little bit more proximal there, right? Let's come to a little bit more. We're just trying to figure out where to land this, and then I think we'll go up.
Right there.
That's good right there. We went ahead with an angiosculpt here, just to go ahead and cut the lesion open. Hopefully get that stent open. Please going up, please. What are you up to now? Go. 8. Keep going.
10.
Take me off DSA here, Ray. See, you can see that it's clearly that internal stent is what's causing the problem. The restenosis is because of that internal stent. You can see the 2 layers. I would go higher here, because you definitely. What's the rated burst of this balloon, guys?
Looks like 40.
14. Yeah, I would go to 14 for
14 or
sure.
14.
You know what? You really want to try to get that supera open. It's not the supera's fault. I just think the other stent deployed into it just kind of, whatever you call, candy wrapper, and that's what it caused the issue. Okay, we're going to leave this down, and then we'll take another picture. DSA, Ray. And then get us an impact DCB. A lot better, right? So
Yep.
now we have the Stelrex open. All right, we're going to use the Stelrex DCB. So what size Stelrex is this?
I was taking the 60120.
So, okay, they chose a larger one because of the old lesion. I don't think it really makes a difference. We're going to use a long 60120 DCB here.
Yeah.
No, you don't need the impact. We have the Stelrex.
Sure.
And the nice thing about the Stelrex is not only that the data is fantastic in complex lesions, I think the Stelrex is probably the most deliverable DCB out of the three. You clearly have other DCBs that are out there, and they all work well, I think, in varying degrees. And the data has you have different data in each one of them, but clearly Impact has the longest term data. I know that currently we're working on the 5-year manuscript, and I can tell you that Stelrex, I'm working with Dr. Leiden on the 2-year manuscript as we speak. So things are going, showing the data is looking really, really good. The 2-year data with the Stelrex has been presented, although not in this lesion subset. So in this lesion subset, we are definitely off-label with the Stelrex DCB. We don't have a labeling for this particular product in this lesion subset. And just as I taught you, when you're dealing with in-stent, it's always an issue. So let me see if it'll pull back a little, and then go through. There it goes. Yep. Okay, stay there. Let's just go proximal. I think right there, do you know?
A little bit.
A little bit more? Right
That's
there,
good.
yeah. All right, we're going to go up here. So once Dr. Guja goes up with the balloon and down with the balloon, I think we'll go ahead
Good.
and take. Why don't you go to room 4? We'll go ahead and take this out. Take our final pictures. We're going to do a final IVUS, and then we're going to get started. We're going to get started. I know you have to help him. Because I have to. He brought the case in for us.
Oh, it's the Venus.
Not for us. He'll do it with us. So how long do you leave the DCBs up, Vishal?
I ideally do it anywhere between 2.5 to 3 minutes. I mean, 3 minutes is what I do. Of course, it requires a lot of patience, but that's what you got to do.
Right. This is when Elizabeth usually gets us chai and samosas.
Karthik, I'm happy that you held PK's hand and the filter didn't move. You know how it
Yes.
is when we both work together.
Oh my
Yes.
God. This is the ongoing battle on who moves the filter.
This is
Everybody,
good.
by the way, I actually have the audience writing to me, telling me to ask the both of you not to move the filter.
Okay. This is going to go with all of us to the grave, so you better be ready for this.
By the way, Vishal, a lot of people have complimented how you moderate, and they've all complimented how our interaction in the room is really collegial, and how they learn a lot from it. I mean, in a lot of the conferences I've attended, a lot of people have come up to me unsolicited and have said this. So it's a compliment to all of you guys in terms of making this happen.
Vishal, we should. I think you should keep this this recording today
Yes.
at your place and probably watch it every day in the morning. PK complimented us. So
I'm going to get emails about this abuse. People are going to say this is abuse.
The reason we do it monthly live broadcast is because it takes me and Guja to recover from the bashing for 3 weeks.
Exactly.
So we look pretty again on the face. So, it's a
Well, the
monthly
next one is in the second week of August. You have exactly 3 weeks. So
Okay.
No, what can we
Actually,
say?
2 weeks. 2 weeks.
It's amazing that we still love him after all this. So.
Flora, let's see if it's something just to make
So
sure.
one question,
Yes,
Fantastic.
Sandeep.
Karthik, what will be your antiplatelet regimen, or would you consider cilostazol? There is some recent data for restenosis. So how do you?
So I always put them on aspirin, Plavix, and cilostazol. I never do any peripheral intervention now unless somebody is on cilostazol.
No. Like post.
No, post. you said.
Post also.
And duration.
I just leave them on cilostazol.
Yeah.
Unless they have cardiac reasons
Mhm.
that they have fluid retention secondary to cilostazol. Every patient, even after revascularization, I just leave them on cilostazol.
And the purpose is?
I'm sorry?
And the reason is?
And the reason is just peripheral vasodilation. That's all it is. I think silastazole is a great medication. It's very cheap. The amount of burden it puts on the patient by copays and everything is also very less. If you really look at it, silastazole is actually probably more important than Plavix over time. There's no data on it. I think symptom-wise,
I think there is a recent, I can't quote it, there was something which came out about silastazole and restenosis. On the next presentation, I'll will make sure to kind of go
yeah,
with
I
that.
think
DSA?
Plavix we stop, right? I think silastazole has a functional
And how long would you
Sitting-
give Plavix or
I
a dual
just give
antiplatelet?
Plavix for 3 months.
3 months. So
Step
1,
on
3. Okay, that's
Cecilia is yours.
Yeah,
here?
Right, you have it.
Oh, I'm sorry.
because this is a high risk. Yeah.
yeah.
I usually leave them in for 3 months.
Another goober distal.
Yeah.
So we have another goober distal, as you
Distal,
can see.
Yeah.
So we're going to go back in with the penumbra.
Yeah, that's fine.
So, for the sake of time, it's 9:15. So I just want to go over what we're going to do here. We're going to go with the penumbra. We're going to go ahead and aspirate this out. And then we're going to do an intravascular ultrasound. And if all looks good, we're going to be done. So I'm just going to show this final penumbra. And we're probably going to have Vishal and Sandeep make some final comments
I'll give it.
and move offline. And then we're going to get this done because I don't think we'll have any major issues here, God willing.
No, I
then
want to
we'll
ask
be
Vishal and PK. PK, you guys put everybody on silastazole also? Or?
Prior to, we never do it long term because I don't think you have a leg to stand on if, God forbid, they have a bleeding complication to have aspirin, Plavix, and silastazole. So we clearly don't do it as a routine.
You guys think there is a lot of bleeding complication on silastazole?
I think it can happen. Okay, I'll be coming.
As a combination, yes. I don't know the data, but it definitely increases bleeding risk.
Yeah, I mean, there's definitely a bleeding disadvantage, but you rightly said there's a significant clinical improvement in the walking distance with silastazole. That's a given. So if they can tolerate all three, they should be, but usually we are always wary because all these patients have other comorbid conditions going on. So it becomes a little bit more clinical based decision or patient based decision to do aspirin, Plavix only versus all three. So it's a dealer's choice, I guess, in this case.
Right.
One question for everyone. Why is she forming that much thrombus? Normally, like we just did a DCB and she's on angiomax. What's the ACT, Asma?
300s.
So why is she forming thrombus?
This is all
It's all chronic thrombus. bro.
chronic
It's just-
thrombus, plaque
it's like-
prolapse. Walk it up.
It's like squeezing out thrombus out of the plaque. I'm telling you, instant restenosis is a totally different animal. I mean, there's no data on it. My personal opinion has been, when you have long stents like this, you form instant restenosis. The focal you get it is, the better it is. Because the amount of, now you have a good flow, the amount of thrombus formation is less. As soon as they form some restenosis, they start having slow flow in the stent. Their whole dynamics change. And I think that slow flow is what causes this thrombus formations in pockets of atherosclerosis. So no matter how much you do, you're going to definitely, especially in long stents. What are you doing?
Ivis.
Oh, Ivis. If it's a focal stent, it's a totally different story. I think this is all because of slow flow.
Okay, we're going to go with the IVUS now. Turn on the IVUS, guys, with ChromaFlow.
What do you think, Vishal?
No, I mean, I agree with you. I mean, there's
ChromaFlow?
I guess the laser excited the cascade, and once you
It's
have.
plaque, guys. It's plaque prolapse. You'll get it right there.
That's right.
No, I don't agree with you.
That's
Sorry,
That's not plaque?
That's thrombus.
that's
That
thrombus.
thrombus.
I think the way it looks, it's adherent to the wall. It's got to be plaque. Thrombus will be more central, but regardless, I think the issue here is now. I think the question of whether you're going to cover it or not comes up because you aspirated twice. We can
Let's
try
take another
again down
picture.
below. Let me go here again and pull back. Okay. See, that's that right there.
That looks like a plaque. That's right on the 3 o'clock. That one. That one.
What you could do is just don't do a DCB. We did a DCB now, and what we do is we just leave her on Xarelto for a month,
Yes.
Yeah.
and then
That's it.
Then
ask
surveillance set.
Plavix and Xarelto,
That's what I would do.
and be done with it. That's
I
what
would just put her on Xarelto or Eliquis, low dose Eliquis for a month.
And then
I wouldn't
do a Eliquis,
duplexer
I
at
would-
4 weeks.
Yeah, I would do Xarelto and then just follow her.
Any particular reason you're doing Xarelto, PK? Or
Because
no?
you have the AFib data to support you, which at least you have some data along with Plavix,
Yeah.
which you don't have.
Right, champion data.
Yeah, we don't have anything with that's AFib, right? Yeah. So what I'm saying is you have nothing else. The wire came
Champion
back.
is PAD.
Right.
That's good.
Are you ready? Inject. Inject. Okay.
Looks okay.
So I think we're going to capture the filter very carefully, and then I think we're going to be done with this. So I think we have a pretty exemplary case here of showing, a very simple ISR case, how the word simple is really a misnomer. I think you saw the utility of intravascular ultrasound and identifying not only what's going on before you did anything, but what's happening intraprocedurally to help guide therapy. So IVUS actually helped us know that there's no stent fracture here, to show that it's really mostly restenotic tissue. And then when we started seeing issues, although it couldn't clarify whether it was plaque or thrombus, it gave us an idea that we need to aspirate prior to do this, because the tissue or the clot was mobile. The filter also was used appropriately as per our algorithm that we developed in Sinai, and you saw the use of laser and the advantages, disadvantages of all the different devices that Ozma so clearly elucidated. So again, I can't thank Dr. Guja for bringing this wonderful case. Dr. Kapoor, as always, and you're expected to be here, so you have no choice. And then Asma for doing the great presentation, and Ray and Elizabeth and Damien. Would like to welcome Dr. Singla on board, and of course Dr. Atul Kukar, who will be joining us in the near future. So again, without further ado, I think we have a pretty good case, and maybe Vishal, you can let them know that we're going to be in the second Wednesday of August rather than not. So see you guys soon. Thank you, everyone.
All right. Thank you, PK. Thank you,
Dr.
Karthik. Great case presentation. I hope everybody enjoyed the case, the talk, the arguments, and the various treatment options available to do this case. Just wanted to let you know, you can watch this case in the archive section by the end of the week. Watch any of our previous live interventions at ccclivecases.org. Please don't forget to send us comments, concerns, questions, and we'll be more than happy to interact. Our next case, as PK suggested, will be next month, August 15th on a Wednesday. So we'll see you then from Mount Sinai Hospital. Till then, have a great week. Thank you.